and welcome to today's podcast where we explore the forefront of critical care medicine. Today, we are honored to have Dr. Bharat Jagiasi with us. He's the Director of Critical Care at Kokilaben Hospital in Navi Mumbai. We all know him as the General Secretary of IACCM, and he's the Organizing Secretary of Criticare 2025, which is going to be held in Kochi. Dr. Jagiasi will be discussing with us the latest ARDS guidelines and innovations paving the way in intensive care. Stay tuned for an insightful conversation with one of the leading voices in this field. Welcome you, sir.
Thank you, Dr. Monalisa, and thank you for the kind introduction, and also Dr. Jaicob, hello to you as well. So it's nice to be on the board. I mean, I'm seeing all through this, the podcasts which have been happening throughout this year. You guys have extremely done well. And being a General Secretary on behalf of ICCM, I should thank you all for doing this for us. So yeah, I'm all ready for this. Tell me, please.
Thank you for joining us. So we'll start with the first question. Could you explain the evolution and significance of the global definition of ARDS and how it differs from the Berlin definition, and what is its utility in clinical practice?
It's a good question to have. So when it comes to the ARDS, if you all know, it all started maybe way back on 12th of August 1967, and this was the time when the first initial statement came in about something called as acute respiratory distress in adults, because initially the same thing was defined in infants. The infants were seen, so they found something of similarity in the adults as well, and the first paper was published on 12th of August 1967. And taking this date, if you all are aware of, we celebrated the first ever ARDS day in India, and I'm proud. I'm General Secretary, and we were the one who initiated by the IACCM. So it was also, I was amazed, up till now, no one amongst the global community has done this ever. So this is how the 12th August comes in. Now every 12th August we'll be celebrating the ARDS day. So this was the term coined. Then came something called as adult respiratory distress syndrome, which happened in somewhere around 1971. And then there was a 4-point lung score, which happened in 1988. And there was an American European consensus conferences where we all know it happened in 1994. And they came with certain statements. And of course, now what we all been following is a Berlin definition of the ARDS. So Berlin definition is being there since long, and we've been following it up. But the problem with the Berlin definition is it's been there since 2012. It covers 4 areas. We all know it. It covers the timing, that is within 1 week of known clinical insult or the new worsening symptoms within a less than 1 week time. We also look at the chest imaging, bilateral opacities, and the nodules in the X-ray or the CT scan. And also the origin of edema should be non-cardiogenic, and we look into the oxygenation level as a PF. Now the whole problem within this is, this came in 2012. So after that, we had the advances in the critical care. So we also started doing the sonography, and there was no understanding of it. How would the definition look when it comes to the sonography? And also we've been using quite a bit of NIVs and HFNCs. So there's a problem within the Berlin definition when it comes to the resource limited settings as well as the resource rich settings. So when the resource limited setting, of course, you need to have the access to the ABG to define about the mild, moderate, and patient needs to be ventilated. And in the resource rich settings, we all been using NIV and the HFNC. So because the definition is such that those patients cannot be labeled as ARDS. So we were losing quite a quantum of patients which are actually ARDS treated with the NIV and HFNC, and we couldn't label them as an ARDS. So this is why a group of, if I'm not wrong, 32 intensivists, critical care specialists, experts in ARDS representing different global societies sat down, and they then came up with a consensus statement which came up with the new definition of the global definition. So it was about the less than 1 week of the onset, it remains the same. So in the imaging, they also added the ultrasonography. So like B lines could be seen on the ultrasonography was also added apart from the bilateral consultation. And in the oxygenation area, if someone did not have an access to the ABG machine, they added the SpO2. So apart from the PF ratio, it was a SpO2 and F ratio. If it was less than 315, you could take it as an ARDS. And they also included the HFNC, the flow rate, if it's more than 30 liters per minute. Again, that patient also be included in the ARDS category. And Also, in the resource limited setting, they said if you feel if it's an ARDS, then the ventilation and HFNC is not required. So quite a bit of additions came down to it. If you allow me, I can share one slide, if I'm allowed to do that, where you can actually see how it varies and what all areas they have looked into. Am I allowed to share? Yeah. If you see this, this is what it looks like. Timing, as I told you, is less than 1 week. Then origin of edema should not be the fluid overload. It should be the non-cardiogenic, and they've added the B lines as well. So when it comes to the non-intubated patient, you can also include the NIV flow rate of less than 30 and CPAP of at least 5 centimeter. So these are the sets which was included. And of course, in the intubated ARDSs, if the ABG machine is not available, so instead of the PF ratio, we could also do the SPO2F ratio as well. And in the resource limited settings, as you all said, they said there's no need of PEEP or the flow rate. You can define those patients as an ARDS. So this is how it came down to this. So I'll just stop this. Yes. So here the advantages is when it's a global definition, we have the broader inclusivity. So we have the new definition which covers more of the patient population, even though they are on the non-invasive ventilation or the HFNC they're applied. So there's a practical implication. There's an application of the pulse oximetry as well. So it improves our overall research potential because the more patients are involved, and the recognition of ARDs also is there in the non-intubated patient, but it has its pitfalls as well. So potential of the overdiagnosis, as I told you in the resource limited settings, they said there's no need of PEEP or the fluoride. So sometimes we might overdiagnose these patients, and the patients which are hypoxic, actually not ARDS, they have the better survival rate as well. So the mortality rate is really low in those patients. So what will overall will happen is, we all know ARDS is a difficult condition to treat. The mortality is very high, but when you take those non-ARDS patients into the consideration, the mortality will really go down, and it might put the pressure on the treating physician who's treating the really true ARDS patient, and the benchmark is when it's really low. Also, the pulse oximetry, we know it could be the bias related to the perfusion, related to the dark skin tones and all. We are not very sure how it's going to play a role. And of course, in certain areas, very low pulse oximetry when the SpO2 less than 70 and all is not really very well studied. So of course, the various clinical trials are on and we are looking into this, but it has its own advantages as well as the disadvantages. I hope I have answered this question as per.
Yes, very nicely. Thank you so much for taking up that question and explaining us the difference between the Berlin and the new definition of ARDS.
Dr. Jagiasi, from the definition, we now move to the management, the key component. And ventilation, as you all know, mechanical ventilation is one of the most key component of managing an ARDS patient. We have evolved from a lot of concepts. So we will concentrate on two concepts which has been, in and out, which has been coming up in the last 1 decade or so. So of that, the driving pressure, that's a critical in managing an ARDS patient. So how does it guide ventilatory strategies?
So when you look into when you speak about the driving pressure, actually what we are looking into is, we all know ARDS is a problem where the lung is affected, lung is injured, and we don't want to injure it more. So when we talk about the ventilator-induced lung injury, so there were many components which came in. It was volute trauma, it was barotrauma, then athlete trauma, that is biotrauma, and also there was something called as ergo trauma which came in picture. So there was quite a bit of fight amongst the pressure versus the volume, whether it's the pressure which is causing a problem or it's the volume which is causing a problem. And the baby lung concept was also coined by Gattinoni. They basically conducted a CT scan of the ARDS patient, and they found that it was not about the stiff lung what we initially thought of. It basically the loss of the lung volume. So the majority of the part is elastic. Elasticity of the lung is not lost. It's just that certain areas are damaged, and this is why the concept of the baby lung came in when they highlighted the gentle treatment. So with all those, the impedance came in picture, where we realized the forces that impede ventilation include non-elastic or the respiratory system resistance, and then the various pressures came in: airway pressure, P plateau pressure, transpulmonary pressure, driving pressure we've been talking about, and the intrinsic P. So from the fight between the pressure and volume, it went down to the stress and strain. So this is what we all started talking about. So stress is actually the lung stress, which refers to the pressure which is required to distend the lung against the counter force which is exerted by the various mechanism. Could be the airway resistance or could be the chest wall resistance. And the strain is again related to the stress and refers in change in the lung volume is what the strain is. So this is where the concept of the driving pressure came in. And meta-analysis was conducted by the MR2 of around the 9 RCTs, where he found out when he was looking into the difference in the plateau pressure and the PEEP. This is what the actual driving pressure is, and this is what we are talking about. So he found out when the difference was more than 15, there was a positively association with the higher mortality. So he also conceptualized, if you allow me to share one more slide, I will show you with all those RCTs. So he came out with a beautiful chart. One second, let's open it up. Yeah, if you look at this, if you see this, it has the different charts available. So the number one, if you see here, the PEEP is constant and the plateau pressure is rising. So of course, the difference in between two is more. So as the driving pressure rises, you look down, the mortality goes up. Then if you look into the second chart, here, as the plateau pressure goes up, the PEEP has also been increased and they maintain the constant driving pressure. The difference in between the plateau pressure and the PEEP is being maintained constant by increasing the PEEP as the plateau pressure goes up, and the mortality remains stagnant. It remains static. They have tried to control the mortality. And if you look into the third, here the PEEP is going, a plateau pressure remains a constant, but they have increased the PEEP. So overall, the driving pressure has come down and the mortality comes down. So this is what was important, and this is what he thought of. This could be the very important component of the stress and strain, and this is where we have to play a role in this, and we have to work on this significantly. And this is where the figure of 17 came in, and the majority of the randomized control trial lung safe study is a multi-centric international study which has been conducted, and it was to conduct the information. So they also documented in that the patient which had the difference between the plateau and the PEEP for less than 15, they had a better outcome, and survival rate was better. And the notion again gained strength when the Bellany et al. In the retrospective study also demonstrated higher driving pressure was associated with the higher mortality. So this is how the concept of driving pressure is coming. And now the major, of course, this is not part of the major guideline. The reason being is the major RCTs are being underway as of now, as we are talking, and maybe there'll be one published in maybe 6 months' time, which will tell us how the driving pressure is going to come in and what exactly the numbers we should be following it, whether less than 15, less than 14, or less than 12, and how do we achieve those numbers. Also, they're going to demonstrate that, and also they'll be working on driving pressure in the lateral position and driving pressure in the prone position. So these are the areas what we are looking into, and eventually will come in play. So it will become an integral part of our ventilation modality, and the difference between the plateau pressure and positive pressure will what eventually we will start monitoring it, but of course it has to be done in the absence of the spontaneous ventilation.
Thank you for highlighting the key concept of what we call as a safe ventilation. Now we are moving towards getting more safer, because the baby lung concept, whatever you're talking about, more safety is more the key in survival. That is why the new concept of the mechanical power came into being. So could you please highlight about what is your idea about what your thing about the mechanical power in ARDS patients?
So it's a good question to have. So as we also spoke about the driving pressure, the mechanical power, I've been talking on this in last 2 years or so, and my first talk was Dr. Monalisa only at Bhubaneswar. I've given this talk on the mechanical power. So as he spoke about, there are various pressures and techniques and the volume techniques. So it's not only the pressure and volume which is playing a role. When we mechanically ventilate the patient, it's the overall energy which is being supplied to the patient. So apart from the pressure and volume, also there are dynamic characteristics like flow, frequency, rate, what we set, and the strain rate. So flow may be considered at the rate at which the given strain occurs to the lung. And frequency, if I talk of, suppose the pressure suppose I take it arbitrary pressure maybe of 30, which is dangerous once, it could be more dangerous for 15 times. So technically, if I am giving that pressure the rate of 8 or the 8 times in a minute, if I give the same pressure for 15 times in a minute, it will be more dangerous. So this is how the concept of the mechanical power and came in. So basically it's the energy which is derived by the ventilator to the entire respiratory system, combining all factors of energy load, which includes the respiratory rate, pressure, tidal volume, flow rate, everything. So this was also considering all this, Gattitoni, he basically calculated and he coined an equation which is called as mechanical power equation, which takes all these factors into play: the resistance, elastance, flow rate, and also the respiratory rate. And it's a complicated equation which comes in. And with that, they calculate, suppose the work is power into volume, then the power is the rate of energy spent, that is work into the respiratory rate. So overall energy would be the power into volume into the energy spent, and there's a whole lot of a complicated equation what it comes into. So all these dynamic factors play an equal role. So if what they say is doubling the tidal volume will increase the mechanical power by fourfold, doubling the respiratory rate will increase the mechanical power by 1.4 fold, doubling the peak will increase the mechanical power by twofold. So with all that equation, they calculate mechanical power per minute. So as of now, it's an all concept which is coming into the play, and we cannot calculate it. There has to be the AI-based calculation, which the ventilator will tell us, considering all this into uh, point. And but what they have concepted is uh, power of less than 22 joules per minute is going to be the beneficial to the patient. If you go beyond 22 joules per minute, it might harm the patient. But again, it's a concept. It's not really come into the practice.
Thank you so much for answering the two critical questions very clearly and very with a lot of evidences. And the PPT is definitely PowerPoint slides is a very added benefit for the viewers to see that. Thank you, Dr. Bharat.
Thank you.
So, Dr. Bharat, the next question is on ARDS guidelines, which we are bringing out this year. So, can you share your insights about this new ARDS guidelines we are developing and highlight the key updates compared to the previous versions and explain the little bit of anticipated impact which it will have on the clinical practice?
Dr. Monalisa, if you ask me what is the best thing has happened as a general secretary in the society, I would suggest these guidelines, because it's been a very good learning experience, and this is the first time ICCM is coming up with the guidelines. We have issued guidelines, and I have also been part of previous guidelines as well. I co-chair the NIV guidelines, I chair the DVT guidelines, but the methodology what we are following in this is the really robust. So we have the search methodologists, professional one, which are part of it. So initially we had a meeting amongst the team, which guideline needs to be reviewed. So we discussed, we cut down on the 5 guidelines. Then we had the search, we had the international expert, Professor Bram Roscher, who's been helping us out with this, the methodology. We have the professional search methodologist. Search will be reviewed by the someone. Then again, we designed the PICO questions. So it's been the total robust methodology which has been formulated. And recently also we had the comment from the Bram Roscher. He said even the best of the guidelines don't follow this kind of a strict and stringent methodology process. So ARDS is one of those guidelines, and I am chairing that ARDS guideline overall section. So we have certain parameters, like if you know low tidal volume, we don't have to beat that and reinvent the same wheel again. So we decided not to write the whole guideline as a whole. So we came down to the certain PICO questions which are not been addressed or where the new studies have come in. So of course the first one is on the driving pressure. So we will be commenting on the driving pressure, and then steroid use. Because there's an ambiguity, there are certain areas which says could be used, there are certain areas which could be said no. Again, the dose and when to use it, and also ICCM is coming up with the first RCT, which is again on the steroids in the ARDS. It's being led by Dr. Sheila Mehta and Dr. Sumitre. So they are also coming up with this, and this is why we thought of including this question over there. And of course, the fluid strategies in the ARDS. We all know neuromuscular blocking agent, the ESICM has issued a statement, but sedation, when to use it, how much to use it, what to use it, also we are coming into it. And we'll also address the phenotype question over there. So we will not come with the overall thing. We'll come with the preamble saying we follow certain gold standard strategies. We will not comment on those, but there's areas where there have been a newer studies available or the ambiguity is there. We'll address those areas, and it will be an interesting paper to see.
Thank you for answering that question.
So, Dr. Bharat, from ARDS management, we will move on to the another spectrum of your career right now. Being the secretary of ISCCM, how do you envision taking our society forward to enhance its impact and influence, especially in India and to our neighboring countries and abroad?
So to answer this, I'm too small an entity because I always say this, my existence is because of ICCM. In India, critical care was not known. No one knew what the intensivist is and what the critical care is. And all the thanks to our seniors who started with the ICCM. So initially the motive was to make society and even the medicos aware about what the intensivist is, and this exists as a critical care specialty. And then they started with the courses, which we have done it, and our bread and butter is from those courses. So all thanks to them. And eventually we gone forward and we spoke to the government with all the efforts, not DNB, DRB also been initiated. So over and all, society has grown by leaps and bounds, and the major intention of the society is education and training, what we have been doing. And what we have brought in is a collaboration. So we collaborated with the different international societies, and also we are collaborating with the different specialties around in India as well. So we collaborated with the API, we collaborated with the Chest Society, SITCON Society, Fungal Society, Anesthesiology Society, and so on. So this is what we are doing. If you remember, my first General Secretary letter had come in and spoke about the inclusivity. So we're trying to include everyone under the one umbrella, and also trying how much of it is possible and reachable to everyone. We are talking, resolving the issues. And as I told you, now we have to go forward for the research. So society has started with the first RCTs as well. We are coming with the robust guidelines, with the robust methodology. So all thanks to our senior leadership, who are past presidents and the previous executive committees who have worked hard for this, and the current committee who have allowed us to have Professor Pradeep Bhattacharya, Dr. Srinivas Samvedan, Professor Sheila Nanan Mehta. So we've been working towards the research more, and we'll enhance we'll also coming up with the wings in ICCM. So what we'll be doing is we'll coming up with the different wings like nephro critical care, respiratory critical care, hemodynamic critical care. So we're expanding our horizon overall, and we are going forward with the super specialties as well, or subspecialties, whatever you name it.
Thank you, Dr. Bharat, for telling about envision about as a secretary of ISCCM. I think we all feel that the leaders, including you, are doing a tremendous job for taking the society forward. Thank you so much.
Thanks.
So we'll come to the last question about Criticare Kochi 2025. So what is the theme and the focus for the Criticare Kochi this year? And can you put some light on the highlight of the conference?
So I think I should be asking the question to both of you, because you both are active leaders and members of the ICCM, and Jacob is a co-organizing secretary along with me. So of course we have the best of the venue over there. It's a mind-blowing venue, and Kerala has got its own country. We all know that. Among the scientific program, Dr. Srinivas Samvedan has really extremely done well. If you look into it, it's very well crafted program. So it covers all the areas. I spoke about the collaboration, we have the Synergy Hall. We will be having a collaborative meetings with the different societies. We have some PG hall for the students, where the basics of the critical care will be spoken about. And then we have the 3 halls where the major sessions will be conducted. We'll talk about the basics as well as advances in the critical care. So it's very well thought of, which covers each and every area when it comes to the scientific session. And when it comes to the overall experience, we are trying to make it good. We'll have the good presidential dinner, gala dinner, and the overall experience of the venue. We are working hard on it, and we'll try our best to have the maximum number of association people around so that everyone enjoys it scientifically as well as otherwise.
Thank you so much. So there's a lot to expect in Kochi. And
yeah, I request you
I'll
all
ask
to
Dr.
register
Jaicob
and please pass on the message to your colleagues, friends, students, and come in big numbers over there and have fun.
Well, thank you, Dr. Bharat Jagiasi, Secretary ISCCM for General Secretary ISCCM, for answering the questions on ARDS, and also touching upon the most important ISCCM guidelines on ARDS, and to end the spiciest thing of the lot, which is the Criticare 2025 is going to happening in Kochi. So looking forward in meeting all the viewers in Kochi in March 5, 6, 7, 8. So with Monalisa and Chirag,
5, 6,
we
7,
are
8,
winding
9.
up.
5th and 6th we have the workshop. 7th, 8th, 9th is the main conference.
Yes.
Monalisa, thank you, Dr. Jacob. Thank you very much.
Thank you. Thank you for joining us today.